Hi everyone, welcome to my YouTube channel where I make pharmacology simple to understand. I am Professor Kennedy Edem Kukuya and I'm happy to have you here. So today we would want to look at a group of drugs that we use in managing a serious disease condition of the brain that affects more than 50 million people globally. So we are talking about epilepsy. Now, in our previous videos, we mentioned that epilepsy involves spontaneous, recurrent, and transitory seizures. And we also mentioned that these seizures occur because there is an influx of excitatory maybe ions into the neuron. Now, one of the structures in the brain that allows for these ions to enter the brain to cause excessive excitation is the voltage-gated sodium channels. And since they are implicated in epilepsy, it would make sense if we give drugs that block their action in order to deal with the symptoms in epilepsy. But how exactly do they work? How exactly do the sodium channels contribute to the disease condition epilepsy, and how do the drugs work? That is what I want us to explore today. So follow me as we take a journey into the world of sodium channels. And so when you pick the sodium channels, we have various sodium channels around the body. Some are found in your cardiovascular system. Some are in your nervous system, but our focus here is to talk about what you find in the nervous system. Okay, now you pick the sodium channels. They are in three states. We have what we call the closed state or the resting state, which is what you find on the board today. And so here, the channel is closed, sodium is outside, sodium is not getting in, so there is no impulses being generated, okay? But then, if you come to a situation where maybe an impulse arrives, that allows the opening of the channel, sodium then rushes into the channel, all right? And so sodium rushes into the channel because the channel opens, and then this is supposed to cause what we call depolarization. And when that depolarization occurs, we are going to have the rising phase of our action potential. Too much of this will cause too much excitation in our brain. But you see, after about 100 milliseconds, this open state of the channel will give way to a third state, which we call the inactivated state. Now you'll notice that this inactivated state, there is this structure that seems to be blocking the channel. So even if an impulse is arriving, no more sodium would be able to enter through this pore to the cytoplasm. So we will not have any more sodium coming in. But remember that in the previous state, some sodium had entered. And so that sodium will keep allowing us to have some excitation, although we are not getting more coming in. Now, the normal thing is that after this state, let's say about few milliseconds, the channel then returns to the closed state. Okay, it returns to the closed state. So this is supposed to be what we find in the normal brain, that the channel goes through closed state, comes to the open or active state, then goes to the inactivated state, then comes back to the closed state. So this is what we find normally. And as we find this, so as I said, you have this happening, and then this would create a loop, all right? So from closed to open to inactivated, back to closed. Now, we need this to be happening, especially after the open to the inactivated to the closed, because if the channel does not return to the closed state, it means that no impulse can arrive to allow it to open, or when the impulse arrives, it will not open again for us to have more sodium entering. So if your brain has to communicate to another part of the brain, okay, without these things happening, we cannot have the brain functioning normally. And so if these happen in a normal fashion, then we should be able to generate impulses that travel maybe with a particular regularity in this manner. But in people that are epileptic, we find a different situation. So in people that are epileptic, there is a possibility that when the impulses are generated because the channel is open, and then later it goes to the inactivated state, the channel is not able to be inactivated properly. And so it means that instead of having this structure blocking the pore, it is not able to block the pore. So the channel remains open and the sodium will rush into the neuron, causing more depolarization and more excitation. Now, it could also happen that instead of the inactivated state returning to the closed state, so that anytime another impulse arrives, we can then open the channel for sodium influx. The channel rather stays in the inactivated state or the partially inactivated state and does not go to the closed state. So meaning that we stay in a state of perpetual or prolonged excitation. And so instead of getting impulses that are like this, like I demonstrated earlier, now we have something more or less like this. There may be another thing comes here, like this, another one. So it means that that regularity that we're supposed to have gotten in the normal brain, now we don't have it anymore. And this is what creates the seizures that we find in the epileptic brain. Let me add that sometimes these problems that I've just demonstrated could happen because of certain mutations in the sodium ion channel. And in fact, there have been some mutations found in certain genes that code for the synthesis of these voltage-gated sodium channels, and they seem to be responsible for some epileptic syndromes like Dravet syndrome, generalized epilepsy with febrile seizures plus syndrome, infantile spasms, and various other ones. Okay, but where do these sodium ion channel blockers, where do they come in? So we have said that if there is a problem with the way the sodium channels behave, we could have excessive excitability that leads to the seizures we find in epilepsy. So how do the sodium channel blockers work? Let's explore that. So what these sodium channel blockers do is that they can enter the neuron and go to block the pore. Okay, go to block the pore here, so that when they do that, and mostly they like to bind to the channel when it is in the inactivated state. So when they block at this place, the channel is unable to return to the closed state. And previously, we have said that if the channel doesn't get back to the closed state, it will not be ready to be conducting again or to open again for more sodium to enter. So instead of now getting these repeated excitations, now we are able to regularize the impulses like we saw in the normal brain structure. So this is basically how these sodium channel blockers do their work. And we have various examples. So we could think of phenytoin, which is one of the prototypes. We could think of carbamazepine, known as Tegretol. We could think of oxcarbazepine. We may think of lamotrigine. We could think of topiramate. Then we could even think of valproic acid. Sodium valproate is a salt form of that. We could also think of lacosamide, one of the newer agents, relatively newer agents compared to the phenytoin and carbamazepine. Now, these drugs would prefer to bind to the inactivated state of the sodium channel, the voltage-gated sodium channels, and then reduce that excitability because we do not have the sodium channels in a state where they could allow more influx. And so we are able to bring down the seizures. Now, aside seizures, because of the action of these drugs, they calm the nerves. In a layman's language, they calm the nerves. So we could use them in mood disorders like bipolar disorders. We could also use them in other situations where there is pain, neuropathic pain, migraine. We could use them in other conditions where excessive sodium influx is involved. And so this, I believe that this is quite simple to appreciate. And I would like to, once again, thank you for making time to watch this video. Don't forget to subscribe to our channel, and we'll come your way next time.